This is the part 2 video of the anaphylaxis during COVID-19 vaccination, emergency diagnosis and management. I am Dr. A. Padmanabhan, and I had posted the first part of the video 1 week back, and the link to it is here. In case you have not seen it, you can watch it by going to this link. Now, in the management, I'll be concentrating on the immediate management of anaphylaxis in the emergency and not the ICU care or the management of a severe anaphylaxis in which the patient requires some long-term care, days of care. This will concentrate on the immediate management, the moment you suspect it is anaphylaxis and what you should do immediately. There are 10 steps which are vital, and we will come into that from the next slide onwards. Apart from having a written emergency protocol, which is very important, it's good to have an algorithm by the side wherever you give injections, so that in the panic situation, you know exactly what to do. You have to remove the exposure, etc. You will have to do the BLS. BLS applies here also. Therefore, assess the patient's circulation, airway, and breathing. I am not going into that. And you will have to call for help immediately. Now, what is most specific is step 4, 5, and 6. And 5 is calling for help. 4 is calling for help, and 5 is the adrenaline injection, which is the meat of the management of the anaphylactic shock. And keeping the patient in a supine position, you can raise the leg slightly, but it is not without controversy, and you might or might not do it. Therefore, positioning, adrenaline, calling for help are crucial after applying the BLS in the initial stages. Now, most patients should be placed in supine position during anaphylaxis unless there is respiratory distress, in which case a sitting position may optimize the respiratory effort. And in pregnant women, this may not be applicable in COVID injection because we are not supposed to give it for pregnant women. But in pregnant women, the position is semi-recumbent position on the left side. This left lateral, semi-recumbent should be head raised slightly, semi-recumbent. And if unconscious, place the patient in the recovery position. Recovery position means he doesn't choke, his knees are bent so that he doesn't turn over. And then he has the hand support the head so that he doesn't turn over and choke in that particular position. Therefore, positioning is very important. You should do it within seconds of it. You should have a place for positioning the patient. And then immediate next problem is that. Now, some people talk of Trendelenburg position, but little controversial. Now, you cannot say it is something wrong. But what is definitely wrong is never allow the patient to stand up. Sitting may be okay in patients with respiratory distress. Standing should never be allowed. Now, even after we have treated anaphylaxis, if the patient had shock and the patient is completely recovered, there are instances in which the patient stood up, went into hypotension, and could never be revived. Therefore, standing is a very dangerous thing. Therefore, you have to see that the patient is in lying position for a quiet period of time. Now, don't forget that severe anaphylaxis is also a shock, and therefore you should treat like any other shock by giving high flow oxygen. Therefore, you will have to give 6 to 8 liters. You may require a non-breathing mask or oropharyngeal airway. Therefore, all these should be required wherever you are, should be handy wherever you are giving the injections. A trash tray might be good to have by the side where you give the COVID injection. Now, you must also remember that when in shock, you have to give 0.9% saline. For an adult, it might turn out to be 1 to 2 liters within a short period of 20 to 30 minutes, or sometimes 1 to 2 hours. I've seen people giving 500 ml in 2 hours in a patient in shock. Please note very clearly that in anaphylaxis also, shock has to be treated with IV fluids in a very aggressive manner. And of course, if the patient is in arrest, you'll have to give cardiopulmonary resuscitation. Regular interval monitoring is also important. Therefore, when you are immersed in giving adrenaline and positioning, don't forget the other parameters other treatment which are due for shock, which has to be considered in anaphylactic shock also. Now this is one of the algorithms which you can have it posted by the side of your injection, wherever you are giving the injection. This is a UK one. And some people would like to have a modified version of it, emphasizing that if there is no improvement, you have to give the intramuscular adrenaline every 5 minutes. You have to give the IV fluid challenge. And if it is ineffective, you will have to give inotropics like dopamine, dobutamine also. Therefore, this is also part and parcel of the treatment of anaphylactic shock. Now, in the next few slides, we will be discussing about adrenaline or epinephrine alone. This is the most important, crucial thing in the management, the decision to give adrenaline, how much you give, when do you repeat it, when do you give the adrenaline perfusion, etc., drip, etc., are very crucial in the management of anaphylaxis. And we will discuss this in full detail. Now, epinephrine is the first line of treatment of anaphylaxis according to all guidelines. It is not antihistamines, it is not steroids, nothing else. If you have not given adrenaline or epinephrine, whatever it is, you have not treated anaphylaxis. Because it has both alpha sympathomimetic and beta sympathomimetic action, causing peripheral vasoconstriction, increased cardiac output, and bronchodilation. It is the only drug that inhibits the release of inflammatory mediators from mast cells and basophils. Not only it stops antihistamine, it releases the inflammatory mediators from mast cells and basophils, and can be given when diagnosis is suspect and even in cardiac patients. Therefore, when you have suspected anaphylaxis, it overrides everything else. Nobody can blame you for giving it for a known cardiac patient. Nobody can blame you when you have given it for a patient which later turns out to be that it was not an anaphylaxis. You have due reasons to suspect at that particular point of time it was an anaphylaxis. You are fully justified in giving adrenaline, and if you don't give, you can be in serious trouble. And if shock is imminent, as already developed, epinephrine may not act IM and may have to be titrated by an IV infusion. Now, the most important thing, the first and the most important therapy in anaphylaxis is epinephrine. If you want re-emphasis, there is no absolute contraindication to epinephrine in the setting of anaphylaxis. Why I'm re-emphasizing it, many times doctors don't give because the child has tachycardia. I've already given salbutamol 3 times, the heart rate is 180, I want to give. Or in an adult patient, he's a known cardiac patient, therefore I did not give. Therefore, these are not excusable, and there is no absolute contraindication to epinephrine, and is written in almost all the guidelines. And on the top of it, delayed administration of epinephrine is associated with poor outcome and mortality. This is very important. It is not only that you are, at any time you give the epinephrine, you are saved medically. No. If you have not given early, you are still liable to be questioned. And on the top of it, the diagnosis can be, as we have already discussed, patients can present with anaphylaxis with symptoms not meeting the criteria for anaphylaxis and yet require administration of epinephrine, such as a patient with a history of severe anaphylaxis in the first COVID injection, who was inadvertently given the second dose and within minutes is experiencing urticaria and generalized flushing. Therefore, if you give a patient a second dose of COVID and he suddenly develops urticaria, and the patient says, I forgot to tell you, last time you gave me, I went home after 3 hours, I was admitted in ICU. Therefore, then, even though it doesn't meet the criteria for a diagnosis of anaphylaxis, in some situations you will have to give adrenaline. One other factor which decides whether we give injection adrenaline in a patient who doesn't qualify or suspected anaphylaxis is the timing of presentation. Now, in the above case, in which the patient developed flushing and urticaria immediately we said that even though he doesn't meet all the criteria, we will give him injection adrenaline. But if the same patient presents after 3 hours to the ER, we know that anaphylaxis can be self-limited. Patient can present at a time when symptoms have nearly resolved or might no longer require epinephrine for acute management. Therefore, if you have a suspicious diagnosis immediately after the injection, you will definitely err on the side of giving epinephrine. If he presents much later, 2 or 3 hours later, but that is also a period in which you can have anaphylaxis, but you think that is probably improving, you might defer adrenaline and keep him under very close observation. Therefore, therefore, the timing of presentations also decides whether you administer adrenaline or not. Since adrenaline is a central point in the management of anaphylaxis, we'll spend some time in the dosage also. And it would be better if you know the dose by heart. The dose given to an adult, what you have to remember, what's most important for us is 0.5 milligram. And that is 1 in 1,000 solution is the one which is normally present in the ward. You should make sure whether you have 1 in 1,000 or 1 in 10,000. Normally you have 1 in 1,000 and 1 in 10,000 is usually available in neonatology. Therefore, when you give 0.5 milligram, you administer 0.5 ml. And this is the dose you give for children about 12 years, teenagers about 12 years, and for adults. And 0.3 milligram or half the dose, 0.25 ml may be the dose, which 0.3 ml may be the dose, is the dose which you give between 6 and 12 years. And 0.15 milligram or 0.15 ml is the dose which you give 1 in 1,000 solution which you give below 6 years. Now, this is almost the same dose as given in cardiopulmonary arrest, but there the maximum single dose is 1 milligram and not 0.5 milligram. Remember that though that's not important from what we are discussing, for children below 1 to 0.5 years, you have to give 0.15 ml, which may not be possible by the normal syringe. Therefore, whenever you vaccinate children below 6 years, you make sure that you have a tuberculin syringe. These are the mistakes that can happen when you are giving epinephrine. The aim of our management is to act before we develop cardiopulmonary arrest. That is, at least we should have given, if you have not given adrenaline before cardiopulmonary arrest, you have failed in the management. Now, the time from exposure to the allergen to the full cardiopulmonary arrest varies. A British study found that the median time to cardiac arrest was 30 minutes for food, 15 minutes for venom, and 5 minutes for iatrogenic infection. And in most of the study in Britain itself showed epinephrine was administered only before arrest in 14% of the patients. 14% of the patients alone you admitted, and overall only 62% received epinephrine. Remember, even in the best of situations, the management, you don't give epinephrine in the appropriate time. And in the situation in which we are now discussing, that is an injection, the median time is only 5 minutes. Therefore, from the time the patient developed the symptom in front of you, you have 5 minutes, maximum 5 minutes before you have given the, you have given the adrenaline. If you have not done it, you have failed in your management. Other than epinephrine, the medicines which are normally administered as albuterol or salbutamol if the patient has bronchospasm, you have some, most of us do give a H1 antihistamine like diphenhydramine 1 milligram per kg, maximum of 40 milligram. Now the problem is that, and sometimes some people even give ranitidine H2 antagonist 1 milligram per kg up to a maximum 50 milligram. And one of the things which is given very often, which we very comfortable in giving, is methylprednisolone 1 milligram per kg or hydrocortisone 2 to 6 milligram per kg per dose. In case of upper airway obstruction, you might give nebulized epinephrine. And some people give glucagon in patients, especially those who have refractory shock in patients who are taking beta blockers. Why I'm telling you in such a hurry is none of these treatment, antihistamine, glucocorticoid, and glucagon have no evidence of any benefit in shock, but it is conventionally many times given to patients even with anaphylaxis, anaphylactic shock, and therefore I will not discuss that in much detail. Now, one thing which I would like to discuss in some detail is many doctors, they feel when there is a suspicion of anaphylaxis, they give antihistamine can be used to treat anaphylaxis initially. Epinephrine is only needed if symptoms worsen. Therefore, whenever a patient develops urticaria and some distress, the doctors would say that let's give him a diphenhydramine IV and then let's wait for that. Now, the problem is histamine is only one of the inflammatory mediators released during anaphylaxis, and therefore definitely it is not the treatment of choice. Oral antihistamine takes around 30 minutes after the onset for an effect. And IV chlorpheniramine has a faster onset, but most of the IV antihistamine can cause hypotension. Antihistamines are not effective against anaphylaxis. That is a basic thing. Therefore, you are sticking your neck out, and prophylactic use does not prevent anaphylaxis. It's another thing. Patients who have history of some allergy, some doctors tend to say, okay, you take chlorpheniramine for 2 days and then come and take the injection. Be very clear that it doesn't prevent anaphylaxis in that way. These things should be very clear. Antihistamine have very limited role in the treatment of anaphylaxis, or probably no role. And don't make this mistake, because if you are giving antihistamine or not giving adrenaline, you're sticking your neck out, and if something, you are committing that there is an allergic reaction, and you have half treated, and you are also medically more in a more difficult situation. One thing to be aware of is, especially when you discharge a patient after an anaphylaxis, is about delayed or biphasic reaction in anaphylaxis. It is defined as a recurrence of symptoms within 72 hours of the initial anaphylaxis without re-exposure to the trigger, and can occur in up to 20% of the patients who develop anaphylaxis, and could involve organ systems not affected in the initial reaction. And no evidence steroids will prevent this, and more common when hypotension was present at the initial reaction, and this is unusual in food-induced anaphylaxis. Now, remember, there is a thing like this. Therefore, you have to be aware of it. Around half of the biphasic occurs within 6 to 12 hours following reaction. Patients with anaphylaxis need to be observed. This is important, especially in severe reactions and those requiring multiple doses of epinephrine. Now, a British study, of course, showed that the median time to onset of biphasic symptoms was 11 hours. That is, 50% of the reactions occurred more than 11 hours after initial reaction. This is a reason one which is a little worrying, because if you develop 50% of the patient developed after 11 hours, and even the NICE guideline says recommends over 16 years be observed only up to 6 to 12 hours after anaphylaxis. But of course, children below 16 years have to be admitted. Now, the importance of this is, as soon as the reaction occurs, you have given adrenaline or not, and the patient recovers, your diagnosis anaphylaxis, there is a tendency for both the management as well as the hospital to brush it aside, to tell the patient nothing wrong, you were okay, the patient also wants to go home. But you have to understand that he can develop, especially if he had no pulse initially, he can develop a reaction in the next few hours, in the next 72 hours, which is 3 days. Therefore, especially if you have given an injection and he had developed hypotension, you had treated anaphylaxis, it might be worthwhile to keep him in the hospital for 3 days. You might be under tremendous pressure to discharge the patient or to tell the patient nothing was wrong, but that is not the right thing to take. It was not my intention to discuss the A to Z of anaphylaxis. I had in front of my eyes the thousands and thousands of health workers all over the world, especially in India, giving COVID vaccination. And I didn't want them to have an anaphylaxis which they were not prepared correctly. And I was more interested in the primary immediate care of those patients, for which positioning and adrenaline are the most important. And both those two are not easy either. That's where even in the best of hospitals, they make huge mistakes. But what have I now discussed? The ICU care, especially the adrenaline drip, how to give it, how to prepare it, how to de-escalate it are very important. Vasopressors are also given in certain situations. Nowadays, even they do ECMO for patients with severe anaphylaxis after some medication. Now, one of the questions which often happens when you go for your postgraduate exam in MRCP or is that when do you refer to a specialist, and more important, the auto injector education. They actually ask you to give you the auto injector adrenaline and ask you to explain or show to the examiner how exactly you will educate the relative. That's not an easy position. I have not gone into all these things because I was only concerned in the immediate management, diagnosis, and management of anaphylaxis in the ER. Therefore, the crux of the issue when I wind up this presentation is that we are on a massive COVID vaccination campaign, but no deaths immediately after due to anaphylaxis will ever be, appreciated by anybody, the public, the patient, or even by the health, the management anywhere where you're working. Because they think that anaphylaxis is very rare and is definitely treatable, easily treatable condition with adrenaline. We have seen it's not always so. It's a condition which is very difficult to diagnose. You can miss it. It is missed all over the world. And appropriate time at which adrenaline injection is given might end up you making more injections than is necessary. Now, anaphylaxis is definitely a treatable potential, but a potentially fatal condition. Therefore, what it has a positive thing is a treatable condition, but that might work against you when you have not given the adrenaline. Majority of reactions do not result in severe outcomes and treatment. Even without treatment, majority of reactions do not result in any fatal outcome. Therefore, most of the even senior doctors, 30, 40 experience, wouldn't have seen a fatal anaphylaxis in their practice. And when they come as experts for you, they may not be very supportive of your cause. Now, the unfortunate thing is unpredictable. This is the most unfortunate thing. Severe reactions may mimic mild anaphylaxis reaction in the first instance. And you have to understand, even the best of definitions, even the best criteria that is now available do not detect all the children who might progress on to anaphylactic shock when they present initially. Therefore, initially to make the diagnosis difficult. Therefore, the health worker or the doctor who is by the side of the patient is in the most difficult situation, not the ICU intensivist who has a diagnosis in front of him. And delay in appropriate treatment also certainly contributes to fatalities. Therefore, you cannot delay, you cannot overtreat very much because a syncope cannot be, or every syncope you shouldn't diagnose it as anaphylaxis. At the same time, you have to diagnose anaphylaxis very early, otherwise you may lose the patient. And any mistake in this patient, not even mistake, every event will become a medical legal issue in which the patients will definitely not understand even if it is not a fatal, the consequences, even if it is not fatal, for the problems that ensue. And therefore, you are there to defend yourself. And your best defense is your knowledge. And that's why I have presented this in full detail. The final message I want to give you is there should not be a slip between the cup and the lip. In fact, many times what happens is, even with all the knowledge and everything, what happens is a big spill between the cup and the slip and the lips. Why does it happen? First of all, it looks very simple when I say positioning. Now just check how many places when you give injection, is there a proper cot available for the patient to lie supine? Proper cot where you can put him in recovery position, supine position, semi-recumbent position. Are they available? please check it. If you are a DMO or if you are the doctor or the supervisor anywhere, make sure that such a cot is available. The second problem that happens is with adrenaline. Is it available? Availability nowadays is not a problem. Where I went, they said there's a crash cart available. Now that's great, but you must make sure that at least you have 3 vials. And the moment you are giving the first injection, you should call, when you call for help, you should call for other vials also to come. Look at the expiry date, make sure it's 1 in 1,000, therefore you know how much to give. More important than this, what I found in some places is the personnel there authorized to give that injection. Many a time, in fact, in immunization in children, only the nurse is given. And is the nurse authorized medico-legally to give an injection during an emergency? I had an instance in which I found out they were not. And therefore, that's a major issue. But now in many of the COVID centers where they are giving the injection, they are big hospitals, they have a code blue and the pay, and therefore the doctors come running in within 2 or 3 minutes. But this is an issue which you should check. Therefore, what I said is very important. There should be no slip between the cup and the lip. And these are the reasons why many times adrenaline is not given on time. When I made a conservative estimate of the fatal anaphylactic reactions that can occur when India embarks on immunizing 60% of its population, at least 60% of its population above 16 years in the coming years, you can expect at least minimum of 300 fatal anaphylactic reactions. Even one of them will be too much, and I don't have to say they will catch the headlines in even national and local TV and channels and etc. Therefore, that has been the reason I want the health workers and the doctors to be well prepared to meet this emergency. I am Dr. A. Padmanabhan, and thank you for listening to me so long. You can find my other videos in this particular address, and I also blog on wordprocess.com, the web address of which is given here. Thank you very much, and goodbye till we see next time.